Buenas noches, buenas tardes a todos. Bienvenidos a la sesión número 62 de la Federación Nacional de Neonatólogos de México. Sean bienvenidos todos a esta hora. Como ya sabían, el día de hoy programamos estas tres sesiones que estamos en la segunda el día de hoy. Eh, Dado que el día de mañana no tendremos sesión el día sábado. Sin embargo, bueno, esta oportunidad de tener a un ponente de primer nivel como es el doctor BHUTANI, pues es para nosotros un honor que haya aceptado el estar el día de hoy con nosotros para presentar uno de sus líneas de investigación y de la que ha escrito un número de artículos que más de alguno de nosotros hemos leído una buena parte. Yo agradezco en lo personal al doctor BHUTANI por aceptar la invitación a nombre de la Federación y para coordinar esta sesión el día de hoy tenemos a la doctora Wendy Medina, quien es la coordinadora, perdón, la presidenta del Colegio Asociación de Neonatólogos del Estado de Sinaloa, y tenemos a la doctora Claudia Quesada, quien es la presidenta actual del Colegio de Neonatólogos del Estado de Jalisco. Pero a su vez, el día de hoy, a partir de estas sesiones, hemos estado invitando residentes de la especialidad de neonatología eh, con el objetivo de que se vayan ellos también involucrando en las actividades de la Federación. Muchos de ellos nos acompañan. El día de hoy tenemos residentes del Instituto Nacional de Pediatría, del Hospital Ojaran de Mérida, Yucatán, del Hospital Morones Prieto de San Luis Potosí, del Hospital Civil Juan y Menchaca de Guadalajara, Jalisco, del Hospital Rafael Pascasio Gamboa del estado de Chiapas y del Hospital Civil Aurelio Valdevieso de Oaxaca, Oaxaca. Sean bienvenidos todos ustedes. Qué bueno que tuvieron a nuestro llamado, y esto seguramente enriquecerá mucho esta plática que seguramente será muy interesante por parte del doctor John BHUTANI. Sean bienvenidos todos. Cedo los micrófonos a la doctora Wendy Medina para que realicen la presentación del doctor BHUTANI. Llamado, y esto seguramente será mucho. Seguramente será muy interesante.
Adelante, doctora.
Hola, muy buenas tardes aquí en México. Algunos buenos días para el doctor Vinod BHUTANI. ¿Qué tal? A todos bienvenidos. Una sesión más de la Federación Nacional de Neonatología de México. Yo soy la doctora Wendy Medina, presidenta actual de la Asociación de Neonatólogos del Estado de Sinaloa. Y es un honor para mí poder presentar al siguiente ponente. Es el doctor Vinod BHUTANI, es catedrático de pediatría de la Facultad de Medicina de la Universidad de Stanford. Egresado de la Facultad de Medicina de las Fuerzas Armadas de India, es neonatólogo certificado y tiene una formación formal como fisiólogo pulmonar, biólogo de la bilirrubina transformacional y experto en políticas de salud pediatra. Además, es un ávido defensor de la salud materna, bienestar neonatal e infantil. Bienvenido, doctor. Lo recibimos. Adelante.
Doctora Nuria. Hello, can you hear me? Hi. Hello, Dr. Vinod. How are you? I'm so sorry. I was having a little technical problem here. We are ready for you whenever you like to get started. Just quick words, greetings from Dr. Moises, Dr. Wendy. We're all so excited and so honored to have you here with us today. Such a huge person to be able to share with us information, all your knowledge as always. So we thank you so much. Obviously, this was just like a really, really brief summary of what they said.
All right. Well, good evening. Buonasera. I'm Vinny BHUTANI, and I'm speaking to you from California, and greetings from the US. It's really a privilege to be here to speak to you. Thank for the gracious introduction and the invitation. We are celebrating the World Prematurity Day and Week, and this is indeed an honor for us of those who are elder in years, who have seen the evolution of the care of the premature babies, now celebrating 60 years of scientific achievements. I'm going to speak to you about bilirubin, and if I can have my slides on, please. We'll speak about why premature babies are vulnerable to bilirubin, and not only bilirubin, but one of its treatments, phototherapy. Most premature babies that we save these days and take care of are dealt with a host of biological threats. Most of them are known to you, and our focus today is on bilirubin and also on the effect of light. Remember, the fetus in utero is generally in the dark as far as we know. So, why does bilirubin and light play a big role in the well-being of premature babies? For this particular section, for the next hour or so, as we converse, I hope you will understand the unique functions of bilirubin, the effect of bilirubin neurotoxicity, and the innovations that we have made with the use of photons in the term of light particles that are bombarded on the babies to manage their hyperbilirubinemia. I have no conflicts of interest to declare, and I'm here purely on a voluntary basis, and I'm not going to speak of things other than evidence. Now, when we think of bilirubin, you generally think of newborn jaundice. The word jaundice comes to mind. Now, we can usually look at jaundice, or we can feel the skin and touch the skin to see if it is jaundice. Or more importantly, we can check a probe to measure the jaundice level by different colors using probes. And most importantly, if we have the capacity, we can draw a sample of blood to measure the plasma bilirubin, which is the real offending or valuable agent. Looking at the baby or touching the baby or probing the baby requires going through several surfaces of the epidermis, the skin surface, the subcutaneous tissue, and then reaching the vascular blood. And chromophores, which are present in the epidermis, vary with people of different pigmentation. And below the epidermis in the subcutaneous tissue, the fat can be a place for bilirubin to be deposited if it is of a longer term duration. But it is a circulation of bilirubin in the plasma as well as in the red blood cells that is the point of interest. But there's another pigment that is present in the blood, and that is the hemoglobin, which can actually interfere with our assessment of that pigment. And therefore, we separate out the red blood cells from the plasma and measure the bilirubin in the plasma. And luckily, the bone is solid enough that really has no impact of bilirubin, and so that acts as an agent. Now, in understanding bilirubin, we know that it's a biological pigment. It has a capacity to fluoresce a little bit, and we use that as a chemical test. We also know that it has its own functional properties. It is a product of heme catabolism. It depends on postnatal age, and there is a bilirubin surge soon after the baby is born, after the placental circulation is terminated. Initially, the bilirubin at low levels has a very profound and useful antioxidant. It is perhaps the best antioxidant known to humanity biologically. But on the other hand, at a higher bilirubin value, it is neurotoxic. And the metabolism of bilirubin is actually quite complex. It goes through a several multi-step metabolism, and details of this are listed in the handout. In the interest of time, I will go through and skip over many of the slides in the handout. The elimination of bilirubin is also a complex process. It not only involves transformation of a fat-soluble pigment into a water-soluble pigment, but to get it from the reticuloendothelial cells down into the urine and stools. And then when we do use phototherapy, we have to worry about its elimination from the skin. At any given time, there's a residual physiologic level of bilirubin, and that varies with gestational age as well as postnatal age. And so this is the spectrum that we will be talking about. The unique properties of bilirubin is that it has a spectrophotometric imprint which can be measured and is usually in an absorbance range of light between 454 to 461 nanometers. And this becomes important to us as we look at delivery of photons on the skin surface. Now the breakdown from heme is well known to you, and I provide you some basic data that you should be familiar with, and that is iron is relieved, you need a heme oxygenase enzyme, it unfolds a ski cap-like configuration of bilirubin into a horizontal molecule, and an equal amount of carbon monoxide is released, which can be measured in the expired breath. The biliverdin that is formed has a relationship to the amount of hemoglobin from which it is catabolized. So this is a chemical entity. You need biliverdin reductase to form the polar bilirubin, which immediately binds with albumin. And it's as binding of albumin to bilirubin that is an important component, especially in a premature baby. Now, bilirubin in the plasma has sites of production mainly in the reticuloendothelial system, transported in the plasma through albumin, and it has a very tight affinity. It's a primary affinity with bilirubin and albumin, and there are other smaller, less stronger sites. The capacity of the serum albumin to bind with bilirubin is known as the binding capacity, and this is an important term, especially in a premature baby. The strength of this bond, how well it connects to albumin and to bilirubin, is a binding affinity, and that can vary based on the physiologic status of the baby, such as pH and carbon dioxide. The amount of bilirubin that is not bound to albumin is minimal. It's barely measurable, but it is a free bilirubin, and because it's searching for something to bind, it will bind either with albumin or with tissue. And so it is a very low level, difficult to assay, and thus usually commercially unable to be assayed unless you're living in Japan. So these three characteristics actually define the properties of bilirubin: the binding capacity, the affinity, and the free bilirubin. What we end up measuring is bilirubin, and therefore we must keep in mind that bilirubin is not a precise measurement of the ability of the bilirubin to function in the body. We need to know these other three characteristics. And unfortunately, our technical science is not mature enough yet to assay these in a living baby so that we can do it clinically. And that's where lies many of the controversies in the management of bilirubin in a premature baby. We all know, especially from animal studies, and this was from monkeys, that soon after birth the bilirubin surges, and as you can see, it rises up to about 5 milligrams per deciliter, and then within a day or two it gradually comes down as the liver matures. Now this is a good postnatal bilirubin surge, and people have attributed to a physiologic or an evolutionary need for the baby to have enough antioxidants in circulation to deal with all the oxidant stress after being born. All right? So this is meant to be a protective phenomenon. We know that this surge exists in human babies also, and we have known it for the last 80 years. In fact, the first study that reported this by Dr. Davidson and his group and Weech showed that the 90th percentile at about 3 days of age in human babies surged to about 12.9. And this was how we defined in healthy term babies a value of what is physiologic, that is below 12.9, to what is above. And we know that is not correct anymore, and that is why we have moved away from the word physiologic jaundice. But as you can see, this history goes back to 1941. Now we know also that if the bilirubin value is high, which was considered to be above 12.9 to be pathologic, that it could cause neurotoxicity. And the excitotoxicity of the bilirubin is right there at the blood-brain barrier, and the mediation of the neurotoxicity is due to the intracellular calcium, which can cause either an apoptosis of the neuronal cell or is altered enzyme activity that leads to necrosis and cellular death. And these sites of injury, mainly happening in the mitochondria of selective neurons, is characteristic of a disease known as connectris. And as you know, that connectris occurs basal ganglia cells, hippocampus, and cerebellar cells, among many other midbrain nuclei. So it's not a general neurotoxin, it's a selective neurotoxin. This was best described in the molecular changes that take place in the baby following excessive levels of bilirubin through a process of bilirubin-induced neurologic damage. And this seminal article was authored by Dr. Wachko and Dr. Terabelli from Italy, who put together the molecular basis of the events that take place when the bilirubin crosses the blood-brain barrier. Now, this has been well described in the term babies, and when you add in the factor of immaturity and the vulnerability of the brain, you have a whole different scenario. And we'll talk more about that as we move along. The damage to the neurons, astrocytes, microglia, and oligodendrocytes are due to a cascade of events that take place described in this article and is worthy of your detailed reading. One of the interesting areas that seems to be evolving right now is the fact that bilirubin inhibits protein kinase C activity in a very dose-dependent manner. And this is the events that take place in the molecular changes of the neurons, where you can have a series of actions taking place that can cause neurotoxicity. And the offending agent seems to be the free bilirubin, which induces irreversible changes to active sites of protein kinase C. And it is in this area a lot of research is being done by our colleagues in Europe as well as in Canada. Being premature makes you more vulnerable. Number one is the gestational age. Because of gestational, as more premature you are born, the more translucent is your skin and there's less subcutaneous tissue. So the light that penetrates the baby is different from the light that penetrates in the skin of a child or an adult like myself. The integrity of the blood-brain barrier is also vulnerable because of the lack of autoregulation in the cerebral circulation. In addition, bilirubin production is higher in a premature baby because of higher hemoglobin levels. And premature babies who are born, especially vaginally, are likely to have more bruises. And as I indicated, 1 gram of hemoglobin will make about 33 milligrams of bilirubin. Thirdly, serum albumin fluctuates. If you do measure a serum albumin value in a premature baby, it is far lower than that of a term newborn baby and an adult. These values are often generally less than 3 grams per deciliter, and they also are slightly of a different chemistry than adult albumin, and we don't know how well this albumin actually functions in binding with bilirubin. And more importantly, we have learned that bilirubin that is bound to albumin is not as strongly bound. The affinity is lower, so that it is easily displaced in the presence of an acidosis, pH is less than 7.35, to hypercapnia with PCO2s above 45, and then also with other organic acids that may be present in circulation, as well as the effect of hypoxemia and ischemia. So, as we try and assess bilirubin values or the bilirubin metabolism in a premature baby, we have to keep in mind that we need to know the total bilirubin, its fraction as that which is water-soluble, or the unconjugated bilirubin, and one that is conjugated and bound bilirubin. Prematurity, because every week of gestational age makes a difference, the bilirubin-albumin ratio, the free unbound bilirubin, the bilirubin binding capacity, a measure of hemolysis either by looking at carboxyhemoglobin or, if you can, to measure expired carbon monoxide, and then the bilirubin that is converted with light, just general light exposure, to photoisomers. And when you measure total bilirubin, the photoisomers are included in the total bilirubin. And all of these obviously interact with each other. So just bilirubin number alone is not good enough. The unbound bilirubin is a complex agent, as indicated. They are available in 2 forms and measured in moles per liter. So it's in a very small infinitesimal amount. And so the technologies that are using to assay unbound bilirubin are now based on nanotechnologies, and devices are being developed in this arena. So as we take all of this information together, and we know that is the free unbound bilirubin that is neurotoxic, we have to be able to understand it, if even though we can't measure it directly in a clinical setting. So the end result is connectors in the premature babies can occur because of the unbound bilirubin that may become in circulation, even if the total bilirubin is not elevated. So you think that the total bilirubin is 9 or 10 or 12, and you think that's okay. It may not be okay for a baby who is 750 gram birth weight. In fact, in a premature baby study for an ELBW less than 1,000 grams, the increasing levels of unbound bilirubin was associated with higher rates of death and neurodevelopmental impairment and hearing loss even at the age of 18 to 22 months of follow-up and possibly later. This relationship between unbound bilirubin and the CNS is also very well described in the article by Dr. Wojcko and Terabelli that gets into the details and talks about the vulnerability of the blood-brain barrier to this agent. Other areas of vulnerability, as I mentioned, and to be described in more detail, are the affinity of newborn albumin to bilirubin, the endogenous ions that may be present, occurrence of perinatal asphyxia because that may release more organic ions, metabolic acidosis, and bilirubin acid such as the free bilirubin. Hypercarbia that can affect the blood-brain barrier and impaired ATP transportation becomes a factor, and the neuronal susceptibility of the immature cerebral neuron as altered by hypoxemia and ischemia. These have a long-term effect. So even though you can get bilirubin values that are reasonably high, but not enough to cause connectors, Dr. Johnson helped describe a syndrome of subtle injuries that may present in babies because of their exposure to bilirubin and low levels of unbound bilirubin, but higher than normal. And these are disorders of a processing system where the ability to hear, the ability for visual motor activity, and for sensory motor activities, perception, language, speech development are altered. And this syndrome are definitions of a subtle neurological disorder short of being connectrous. Connectrous is when damage has already occurred, but short of cell death, you may have changes in neuronal function which by themselves could be lifelong. This syndrome has yet to be proven with long-term follow-up studies and are more important in a premature baby where there may be neurological developmental impairment with undertreated hyperbilirubinemia. So a spectrum of this disorder was described by Bratlett way back, where if you look at a range of bilirubin, you have a safe level of bilirubin, a worrisome level of bilirubin, an unsafe level of bilirubin, and then the dangerous bilirubin value, which causes irreversible damage. And it's in the worrisome, unsafe area that these neuronal changes could be reversible. In dangerous hyperbilirubinemia, you get cell death, multiple cell deaths, increasing severity of connectors, and long-term disability. With unsafe levels, where you may see changes in language, speech, and neuromotor disorders, that is where we need to focus our attention to assess the effect of bilirubin. So all of this at this point is hypothetical, it's conjectured, and it's opinionated, but gradually, as you can see, the evidence is being collected and we are seeing measures of molecular injury occurring short of connectors. Now, what is the risk of connectors in premature babies? Why are more premature babies more vulnerable to connectors? It's just not their age, but the fact that there is a vulnerability. And this was probably best defined by Virginia Cross way back in 1950s when she looked at the incidence of connectors in babies less than 36 weeks of gestation. Remember, this was an era before we had protection from Rh disease. Rh immunoglobulin was not yet developed. Phototherapy was not yet being used. So we saw the true pattern of severity of connectors from high bilirubin values. And you see that the incidence of connectors in babies less than 30 weeks of gestation was 10.1%. Now, with Rh management, as well as with availability of phototherapy, that incidence is extremely low and has really not been estimated, but obviously way less than 1 in 10,000. So those are good numbers to know about connectors, but as I said, there are the subtle natures of neurological injury in these babies that we still need to be following very closely. What are the normal values of bilirubin in a premature babies? We really don't know because they've not been measured, and most babies get treated now with phototherapy. In a very recent paper, Jagathisan from Toronto and her group put together data from about a couple of thousands of babies who were of 29 to 35 weeks of gestation, all more than 28 weeks of gestation, and defined their hour-specific values and defined percentile values. And these were bilirubin values before the use of phototherapy. And as you can imagine that if the babies' levels, if these babies were not treated with phototherapy, the levels would have been higher beyond 96 hours of age. But you can see the cluster before 96 hours of age, that there's a spectrum of bilirubin and they range immensely for each baby, as one would expect. We don't know the significance of this nomogram yet to see how we can use it clinically to make a decision, but it helps us understand that not only do we need to know about bilirubin, but we need to know of other added risk factors. I briefly mentioned to you Rh disease. Hemolysis is a major factor in adding to neurotoxicity. Bilirubin production, the rate of bilirubin production, actually has an impact on the ability of bilirubin to bind with albumin. And so the binding gets altered. And so with that, because of the rapid production, the albumin cannot keep up its binding, and a higher level of unbound bilirubin is likely to occur. With increased production, there's a total bilirubin load, and so the bilirubin is then outside the circulation and not always bound to albumin. And this relates probably to the fact why hemolytic jaundice leads to neurotoxicity, and we have reports of long-term effects and a higher incidence of connectors related to hemolysis. Based on these observations and these worrisome observations, the AAP recommends that the infants with hemolysis be treated slightly differently, and that until we know better, we use lower bilirubin thresholds to initiate phototherapy. Similarly, that once you stop phototherapy, you have to worry about the bilirubin continuing to rise after the phototherapy has been discontinued, and so you can get a higher incidence of rebound hyperbilirubinemia. So you need to keep that in mind. We already discussed briefly the issue of bilirubin displacement. If bilirubin is displaced from the albumin, you get more unbound bilirubin in circulation, and this will occur in the presence of acidosis, pHs less than 7.35, hypercapnia, low albumin values, drugs such as sulfas, indomethacin, ibuprofen, and as well as intralipid infusions and non-esterified fatty acids. So all of these have to be kept in mind, especially in a premature baby. Now let's look at the treatment, because you're trying to prevent neurotoxicity. Neurotoxicity can be prevented, now it has been shown, with the use of phototherapy, both as a preventive as well as a rescue measure. This is the capacity of us to prescribe photons in the form of photon particles to degrade the intravascular bilirubin. That is the purpose of phototherapy. And the history goes back well to the time when a nurse noted jaundice being bleached with sunlight, to a resident who noted the effect of bilirubin on a blood sample and the effect of sunlight on a blood sample. And that is why I show to you how the sun can have an effect. This is a spectrum here of the solar light measured at sea level. And you can see that the range of light varies from about 250 nanometers to about 2500 nanometers. And that's a fairly high spectrum, and the irradiance is incredibly high. You only have to stand under the sun at noon to know the intensity and heat of sunlight. The phototherapy that is used is this blue bar that just showed up. I'll put it, make it go away. It comes back on, and you can see this blue bar is the amount of light that we need for phototherapy. So it's only a minimal fraction of the sunlight that is needed. That is the therapeutic light. This bar that goes away and comes back. All right. So this use of sunlight helped the entry of a new field in bilirubin called bilirubin photobiology for a neonate. What evolved from these studies was that the range of wavelength of light that was the most effective was 460 to 490 nanometers, or the blue light. Okay? The ideal wavelength, as shown recently by Dr. Eberson, is about 476 nanometers. We distribute it evenly through one plane of the body. We measure its intensity to be between 30 and 35 microwatts per centimeter square, keeping in mind that in the sunlight, if you're standing in the sunlight in your parking lot, it's about 1500 to higher irradiance. The amount of bleaching that can occur for jaundice is almost immediate. You put a white linen with a yellow stain in the sunlight, within a few hours, that bleach is completely gone, but begins to degrade almost immediately. So it has an immediate effect. And you can use multiple sources of light to expose as wide a surface of the body area. And when you do that, you want to avoid shadows. The other thing that we learned with photobiology of bilirubin was you do not need ultraviolet lights. In fact, you filter away the ultraviolet lights. And so in many places of the world, people think that the use of phototherapy is the use of ultraviolet light. That's not correct, okay? You do not wish to expose babies to ultraviolet lights, because if you yourself are exposed, and especially if you happen to be white-skinned with minimal pigment, you are more likely to develop skin cancers. So all good phototherapy devices have filtered out the ultraviolet light. Please check your device. Also, when you place a baby in sunlight, direct sunlight, unless the window glass has filtered the ultraviolet light, which most glasses do these days, you want to be careful. So no direct exposure is needed for phototherapy with ultraviolet lights. Now here's a range of the light wavelength. We've talked about it. So this is a rainbow. Shine white light through a prism and you get a rainbow. And you see violet, blue, green, lime green, yellow, orange, red, and so on. Each has its own wavelength. The wavelength that is important clinically, therapeutically, needs to match that of bilirubin. And that is this level between 460 to 490 in the blue-green spectrum. Remember, once the light hits the skin, it has to penetrate through all those different layers before it actually reaches the plasma bilirubin where it can have its effect. Because plasma bilirubin is moving very rapidly through the skin, and so it acts almost like a dialysis system, and you can have the lights kind of degrading away the bilirubin, creating the photoisomers that are water soluble. Now, these light wavelengths penetrate the skin differently because they are of a different intensity. So as shown in this adult skin, you can see that the blue light penetrating only up to the dermis, but green light going up a little lower, and then the yellow and the red and the orange lights going deeper into the subcutaneous tissue, and so on. So that is dependent on the thickness of the skin as well as where the kind of light wavelength that you're using. So in the 470 range, we are using the light to penetrate just below the epidermis in the skin where the microcirculation is. And you know how vascular that is, because if you're shaving your face or your legs and you get a nick, you immediately bleed. That's the microcirculation. That's the bilirubin in that circulation that the light is acting upon. Wavelengths less than 400 get into the ultraviolet range. That's what you do not want to expose because it will bombard the surface of the skin. That's why the cancers of the skin are most worrisome. Now, if you follow the bilirubin as it is being formed and being transformed in an HPLC device, you can see different peaks of bilirubin. Peaks 1, 2, and 3 are the photoisomers that appear almost immediately, and these are formed literally in picoseconds. This is the reduction in bilirubin, the stereo isomerization of bilirubin that is taking place within seconds of exposure to light. It makes the bilirubin water soluble and it makes it less neurotoxic. So once you turn on the light, you are immediately reducing the risk of neurotoxicity. That is why when you're giving phototherapy as a crash cart approach, you want to be able to give the light immediately even while you're doing procedures. All right? Waiting for 5-10 minutes because the baby wants to settle down or somebody wants to hold the baby doesn't make sense, because if the bilirubin is high and you have a baby who is symptomatic, you want to treat that baby immediately. So that is the crash cart rationale for use of phototherapy. And the isomers, as I indicated, are formed within a few seconds, but a peak occurs by about 2 hours, and so by 2 hours of age, most of the effect of phototherapy is then just plateaued and continued along with the natural elimination processes. So the standard of care for phototherapy has been well established now. The AAP guidelines provides you preventive use of phototherapy for severe hyperbilirubinemia. We provide you magic numbers for the thresholds of phototherapy, because we do not know at what precise bilirubin level the brain is going to get damaged. Because as indicated, there are 3 different factors or characteristics of bilirubin that we are unable to measure at this point. So these numbers have been established by consensus. They are phototherapy guideline numbers, and they take into account the safety of general practice. So there's a little wiggle room, but they help you start an intervention in a preventive manner. Rescue phototherapy occurs if a baby is brought in to you with an extremely high bilirubin value. And again, the extremely high bilirubin value is a relative word, all right? It depends on how rapidly it has risen. And so you have to keep that in mind, but if you know the bilirubin level is higher than what you normally see, or the baby is symptomatic with signs of bilirubin encephalopathy, you need to move fast. That is rescue, and that is where the crash cart approach becomes important. It's a standard of care, it's a kind of wavelength you select. So the blue-green light is the correct wavelength between 460 to 490 nanometers. And these days, you can only precisely deliver it with an LED light. Thus, the use of fluorescent lamps and halogen lamps are out of the window. They are no longer the standard of care because they cannot give you this very narrow spectrum of light, which then can go and work directly on the bilirubin value. The reason we want to be precise, because we do not know what is the toxicity of the extraneous wavelength. You know, what is the toxicity of 450 versus 500? Maybe none, maybe little, but why take a chance? And so having a narrow spectrum that is therapeutically known is the intervention to seek. And that at this point is through LED lights. Irradiance, or the exposure of the intensity of the light, is in the range that has been defined by Dr. Tan and others, those who have followed that work, is between 25 to 35. Anything above 35 is not needed. We do not know how toxic that is, because remember, when you're bombarding photons onto the skin, that is an oxidant injury, all right? You don't want to expose the baby to oxidants, so there's no reason to give them extra oxidant photons. In a premature baby who weighs 500 grams or 400 grams, maybe 25 is too much. And so we'll talk a little bit about that, as to what are our choices so that we can use effective light in babies who are extremely low birth weight. The light that is distributed on the baby should be uniform, so that the footprint of the light, there is the same intensity, same wavelength, the same irradiance, whether it's being delivered to the right shoulder, the left shoulder, the right knee, the left knee. It should be a similar number. There should be a uniformity. And then once you deliver the lights, you should check for response. So as as I indicated, the photoisomers will start to plateau at about 2 hours of exposure. So that is why the first bilirubin after the start of phototherapy should be done at about 2 hours interval. There's no point doing it earlier. All right? You can if you wish to, but if you're going to stick a baby, at least wait for 2 hours of light exposure to see if there's a measurable change in bilirubin. Keeping the standard of care in mind, we already have discussed this. So in premature babies, Dr. Mezels and myself and Dr. Stevenson and Wojko, we kind of gathered together as experts with diverse opinions to come out with numbers. We again made magic numbers for premature babies between 28 and 35 weeks of gestation, and again based on our concerns for enough preparation and safety measures and having a reasonable window where we could have an effect, we defined numbers at which we could clinically treat babies. Again, these numbers are purely driven by consensus. They are informed more by the bilirubin albumin ratio numbers, but they are not actual evidence-based numbers. Hopefully that will change over the next few years. Using those numbers, we have developed a clinical decision support system, like a toolkit, an electronic toolkit that is attached to our EPIC system of electronic records, so that when a bilirubin is provided to us for a baby at, say, 32 weeks of gestation, it tells us at what level should we either consider phototherapy or start phototherapy or consider exchange transfusions. So this electronic system is available on an open access. It's called PremiBilirx, and Dr. Arain, one of my fellows, worked on this device, and it's in practice here at Stanford. Some of the research that we're doing looks at things that I just talked about: bilirubin capacity, the affinity, the ratio between unbound bilirubin to total bilirubin. And if you look at that axis, it helps us define bilirubin values in a population in whom that value would have been hazardous, worrisome, or put the baby at risk, or then those babies just needed to be observed. Now, in this particular study that we reported a few years ago, we see that most of the babies could have been treated by simple observation than not using phototherapy. And those who are at risk should have been treated with phototherapy. Those who are worrisome need to be treated more aggressively. And those who are hazardous, we were not fast enough. All right? So this is another way that we hope that we can evolve the science of use of phototherapy in a premature baby. The reason we've talked about these parameters is because we are concerned about the neonatal phototoxicity. As I said, it's an oxidant, right? So question is, does it cause oxidant injury? Do photons itself cause oxidant injury? That's a question that needs to be answered. That if the bilirubin is reduced in a baby, are we reducing its antioxidant activity? So phototherapy acts as a double injury, as like a double jeopardy, that not only are you giving photons for the treatment, but you're taking away the antioxidant effect of the bilirubin. And that is a difficult thing to study. Do photons protect the neuronal system? We don't know that. Or do they hurt? Initially, there used to be a thought that when phototherapy was given to babies, it was affecting the brain neurons itself, and that was never proven to be true. Are photons mutagenic? So in a cell culture, you can cause DNA to be harmed by exposure to light. But luckily, that happens in the skin surface, and most of that is lost, so it has no long-term effect that we know of. So There's always a thought, we've talked about ultraviolet lights as being a factor for being more mutagenic, but is the phototherapy in the 460 to 490 nanometer range mutagenic? More importantly, does treatment save lives? And that we know it has. That with the advent of phototherapy, we have prevented exchange transfusions, more babies are treated and prevented from getting connectors, and more babies have had healthier lives. So it has saved lives now after 60 years of use. In the premature baby, especially the extremely low birth weight baby, there have been certain controversies because you're coming there to the near areas of viability. There have been two long-standing controversies of use of phototherapy in the very, very premature translucent baby. The first is, how low is the bilirubin to be before it causes neurotoxicity? That's an important question. You know, babies with bilirubins of 5 or 6 that we used to call as physiologic, are they okay for babies at 500 grams and 400 grams? And we don't know the answer to that. The second came from a study done back in 1974, so this is an age-old controversy, is that are extremely low birth weight babies more prone to mortality? If you look at the relative risk of these data on mortality from 1974 to 1976 trial, the relative risk was almost 1.5, but the confidence interval crossed over 1, and so it was non-significant, but this trend was bothersome. And so the next trial that was done with phototherapy by the NICHD looked at this fact a little bit more closely. In this trial that has been talked about a lot, we compared aggressive phototherapy with conservative phototherapy. Aggressive phototherapy in babies less than 1,000 grams were when phototherapy was started at less than 24 hours of age, or if the bilirubin value was 5 milligrams or above, considering that 5 milligrams could be toxic and therefore should be treated with phototherapy at 24 hours of age. The conservative arm for this babies was to start phototherapy for bilirubins of 8 and above, because we didn't know whether 5 was toxic or not, but we knew that 8 was most likely to be toxic. So that's why these two arms were separated into aggressive, shown in red, and conservative, shown in green. For babies between 751 and 1,000 grams, it really mattered on age, so that between day 1 and 7, the need to start phototherapy was for values above 5, between 8 and 14 days of age if it was above 7, considering that the postnatal age may have had a better effect on bilirubin binding or serum albumin values. The conservative arm listed the bilirubin value to be above 10. Now keep in mind this conservative arm where phototherapy was begun at about 10 milligrams per deciliter. It's a very complex study that is worth reading, but I'll highlight the main points. Once again, for babies less than 500, between 501 and 750 grams, aggressive phototherapy was associated with a higher trend of mortality, 1.1. And again, this confidence interval narrowed but was still crossing over 1. And that's why this controversy remains. So with Bayesian analysis, this controversy indicated that there was a trend towards increasing mortality, but not proven increase in mortality. Bothersome, worrisome, needs to be elucidated, needs to be worked out. But there is a question whether the oxidant effect of photons on the very premature translucent babies is toxic to their life. For babies between 751 and 1000 grams, there was no effect on mortality. So it was safe for life. But what the RCT showed that in the conservative arm, for babies with bilirubin values above 10 milligrams per deciliter, there was a long-lasting neurological effect, which was profound, going up to 18 to 22 months of age. The confidence intervals was between 0.74 to 0.99. Okay, so that tells you, do not let extremely low birth weight babies get bilirubin values above 10, period. No questions asked at this time. So there's a protective effect on neurodevelopmental impairment, especially profound impairment, with the use of phototherapy, that it is beneficial. So use phototherapy early and use it aggressively for lower bilirubin values. But in the very premature baby, our findings suggest where we know that we are preventing neurological impairment in babies between 501 to 750 grams, that there is a propensity or a trend towards increasing mortality. And therefore, there we still need to be balanced and we need to find innovative solutions. So, research in progress. What can we do? What are our choices? So, to innovate, we try and change the exposure time. We can make phototherapy that is continuous to being intermittent, or we can vary the surface exposed. We can give excessive light by keeping it circumferential, or create a cocoon, like a sleeping bag of LED lights, and have the baby sleep in that, so you have an increased surface area, or you can reduce the surface area. Those are our choices. An innovative choice was to cycle phototherapy, and I'll explain what cycling means. And that was to give phototherapy on and off, on and off. In this strategy, the idea was to have a safer strategy for extremely low birth weight babies, decreasing the photon exposure while providing and achieving aggressive bilirubin reduction. This was proposed by Dr. Tyson and his group, and they talked about cycled photon exposure. The light goes on for 15 minutes and it's off for 45 minutes. That's one cycle. Then they compared this to a 30-minute on cycle, a 30-minute off cycle, a 45-minute on cycle, 15-minute off cycle. Now, this does not mean that a nurse had to have a stopwatch and put the lights on and off. This can be done in an automated manner. And this clinical trial is ongoing and nearly conclusion, and we hope for its results soon. But it seems to be effective because the arm for 30 minutes on and off was taken off, and now we're comparing 15 minutes on with 45 minutes on to see what is effective. The other thing is to find the correct wavelength, and that's why my emphasis on correct wavelength. Ebbison and al. Have shown 476 in the blue-green spectrum is the most effective light at the blood through the skin. And the range is 466 to 486. So if you go back to the wavelength diagram, you can see the kind of blue light that we want to use. The question that remains is, where is the light acting? Is it on the skin surface? Is it at the subepidermis? Is it in the vascular level? Or is it just on the bilirubin molecule? And that has to be differentiated in the future in vivo studies. The homogeneity of light is something that we have tried to change in clinical practice. We measure the irradiance not only at one site, like the umbilicus, but we measure it at 5 different sites. And we hope that those 5 measurements are within 5 microwatts irradiance of each other, so that it is as homogeneous. Or else you could look at the light and place it on this board that we have shown here in yellow, green, and blue, where each square centimeter measures the irradiance of the light. There are photometers embedded in that board. And so if you shine a light, you can see if the light footprint is homogeneous. And in this particular light, example that I've shown is fairly homogeneous. You see yellow all over the place with numbers which are very close to each other. But since we don't have the board at our bedside in our clinical use, what I recommend is that we measure light at 5 sites, upper shoulders and groin and umbilicus, and look for the closeness or homogeneity of measurement. Lastly, looking at the photodegradation process with isomerization, we know that it occurs in circulation, that bilirubin has to be bound to plasma for it to be effective. The action is in the dermal skin circulation, and it moves fairly rapidly within picoseconds and much lower in the skin and the fat tissues. And we know that the jaundice is exposed to lights, so we know that this is how the light is acting, and maybe we can study it better so that we can help move it faster. So in summary, as I come to a conclusion and answer some of your questions, is that premature babies are at an increased risk of increased bilirubin production loads. And this can sustain itself to lead to an adverse outcome, either due to neurotoxicity of the bilirubin itself or due to overtreatment with phototherapy and use of exchange transfusions. Clinicians should rely on expert consensus opinions to guide timely and effective interventions until precise evidence is achieved. There's evolving evidence that the judicious use of photons can minimize both bilirubin neurotoxicity and phototoxicity. Most preterm babies will have a benign course, though many of them are overtreated with phototherapy at this point. There are some babies that we do need to worry about, and that is prematurity for every week of gestation less than 39 weeks, babies with low albumin, sepsis, shock, and surgery, babies with inability to bind albumin correctly with bilirubin. Safe practice is that albumin times 7 is a point at which you should be worrying about that bilirubin value. So if you do measure albumin, that's a guide that we have generally used. Phototherapy affects mostly because we have seen declining rates of exchange transfusions. Rapid bilirubin rises more than 0.25 milligrams per hour, such as with RH disease, G6PD deficiency, or ABO incompatibility, are the ones that you worry about the most. They're most effective to phototherapy. If there's a direct bilirubin above 2 milligrams per deciliter, that's problematic, and here it is not a good idea to use phototherapy. With that in mind, there are a few take-home messages. Phototherapy is a drug. It can be toxic. Hemolysis is not good for brain development. Infants who are vulnerable for each week of prematurity. Rapid rate of rises of bilirubin are not good for you, and subtle bilirubin neurotoxicity or bind may be lifelong. Thank you very much for your time, and I will try and answer any questions.
Muchísimas gracias, doctor BHUTANI, por esta excelente ponencia, este maravilloso tema. A continuación vamos a dar inicio a la sesión de preguntas y respuestas, pero como bien lo mencionó el doctor Moisés Quiles al inicio, se va a hacer de una manera un poco más dinámica. Invitamos a diferentes residentes de neonatología de la República Mexicana y algunos médicos adscritos, y a continuación le voy a dar la palabra a la doctora Álvarez Corona Silvia Araceli, residente de neonatología, para que haga su pregunta.
Hola, buenas tardes. ¿Cuál es el seguimiento recomendado en estos pacientes pretérmino que cursaron con esta patología cuando hay sospecha de que haya secuelas neurológicas? Si hay algún protocolo o se recomienda específicamente la resonancia o algún estudio.
Doctor, what is the follow-up when we have babies that we're suspecting of neurological sequelae, what do you do? What's the protocol? Do we do MRIs? How is that handled?
Yes. So any baby in whom you have had to do an exchange transfusion, that is the most worrisome baby. Because if you're worried about doing an exchange, that baby probably got connectors. So in those babies, an MRI would be important. Generally, an MRI, you can't do an MRI acutely, though you can, but you don't want to interfere with the treatment. So an MRI is important, definitely by 1 year of age, looking at T2 images for the basal ganglia. But prior to 1 year, that is the worrisome period. So the baby that you worry about, the, the most sensitive signs of neurotoxicity is loss of hearing, the sensory neural hearing loss. And to be able to do an automated brainstem response becomes a very good clinical test to do. And then you follow that up if the baby refers. And then that baby should again be evaluated at 1 year of age. Clinically, what you look for are signs on the baby's face. The baby starts to have a face that stares, is a non-blinking eyes with flat faces, an expressionless face. The baby looks at you but is not focusing. And then you start seeing signs of neuromotor changes with the delay in muscle tone development. It's as subtle because it can both be hypotonic and hypertonic. So watch the baby waking up from a sleep state and see how violently the baby changes its tone or how slowly the baby changes its tone. When a baby wakes up, there's a gradual increase in tone. But if the baby startles and wakes up like that, that is a worrisome situation. If the baby is so limp, that is a worrisome situation. So those subtle changes, and as the baby starts to grasp or rattle, that movement abnormalities may become more apparent compared to a healthier baby. Those are the subtle signs.
Okay. Menciona el doctor que, bueno, en el escenario de que tenemos bebés que tuvieron exsanguinotransfusión son los que son más preocupantes, ¿no? Porque, pues obviamente si ya estamos tomando en cuenta que necesitan una transfusión es porque ya tuvieron kernícteros. Se puede hacer el estudio de la resonancia de manera aguda, pero no hay que interferir con el tratamiento. Definitivamente la resonancia magnética se tiene que hacer al primer año de edad para ver lesiones en ganglios basales, pero antes de este año es el periodo preocupante. ¿Qué es lo que se puede realizar? Por estar haciendo los estudios de la respuesta auditiva en los bebés y dependiendo de cómo salga esto, pues darle el seguimiento nuevamente al año. Menciona también que clínicamente pues estar pendientes en los seguimientos con las señales en la cara del bebé. Bebés que no ven fijo, que tienen una cara sin expresión, bebés que te están viendo pero que no enfocan. También cuando empiezan a aparecer los problemas motores, que pueden ser cambios sutiles, porque pues el bebé puede estar hipotónico o puede estar hipertónico. Hay que ver cómo actúa el bebé cuando despierta, porque generalmente cuando este bebé despierta hay un cambio gradual, pero si cuando se despierta ya está como saltando, si es un cambio muy rápido, entonces ya nos va dando datos muy sutiles de que tenemos que darle seguimiento a este bebé.
Muy bien, muchísimas gracias. A continuación, la doctora Claudia Quesada. Adelante, doctora.
Sí, buenas noches a todos. Soy la doctora Claudia Quesada del Colegio de Médicos Neonatólogos de Jalisco. Quiero felicitar al doctor por su gran aportación académica que nos está haciendo el día de hoy. Y doctor BHUTANI, preguntarle acerca de la prevención. ¿Qué hay de la prevención para los pacientes extremadamente prematuros y con extremadamente bajo peso? ¿Cómo podemos incidir en la prevención, dado que no se sabe la neurotoxicidad, las cifras con las cuales se llega a tener un daño neurológico?
Yes, good night, Dr. Vinod. Just This is Dr. Claudia from Jalisco. She wants to thank you so much for the great academic apportation you just did today. Her question is regarding to prevention. How would we prevent with patients that are extremely premature with a weight that's extremely low? How can we prevent this situation since we don't know the values to neurotoxicity?
So that is the most fundamental question where research is going on, but we still have to practice. So for babies less than 1,000 grams, what we have done is followed the NICHD protocol for the research protocol as a clinical management tool for using the aggressive arm, not the conservative arm. And we apply that even for babies at 501 grams to 750 grams. For babies between 500 grams to 750 grams, rather than use a irradiance of 30 microwatts per centimeter square, we have lowered it to about 20 to 25 irradiance while we are waiting for the results of the cycled phototherapy, because that will allow us to be more cautious. So what we try to do is to try and keep the bilirubin values between 5 and 7. So it may mean that we check the bilirubin every day, and so we have the bilirubin level checked. If the baby's bilirubin is down below 5, we'll stop the phototherapy. We know that tomorrow it may go up to 6 again, and we'll then have to restart the phototherapy. So end up practicing a day on phototherapy and off phototherapy based on the bilirubin a daily bilirubin value. And so we try not to have the bilirubin value go above 8. We definitely don't want to have it go above 10. And we keep a daily check on bilirubin, especially for the first 2 weeks. So we're very cautious that way. And to prevent, if the bilirubin is at a higher level, then we don't increase the intralipids to 2 or 3 grams per deciliter intake, but keep it at about 1 gram per deciliter intake. And we avoid multiple drugs if we can avoid it. And obviously we're managing the metabolic acidosis. So in babies who are unstable, we are very aggressive with phototherapy. We don't minimize it and make sure it isn't as if the light is not on the baby all the time. But we are checking levels on a daily basis and adjusting. And it's a pain for the nurses to take the lights on and off every day because of getting the devices to the bedside.
Thank you, doctor. Menciona el doctor que esta es una pregunta muy fundamental, donde todavía están en investigación ahorita, pero que sí es algo que tenemos que tomar en cuenta y que tenemos que practicar. En el caso del hospital donde está el doctor, ellos utilizan con bebés menores de 1000 gramos el protocolo por la NHCP del manejo clínico. Están utilizando un tratamiento agresivo de la fototerapia y lo aplican para los bebés que pesan entre 500 a 750 gramos, hasta en estos. Donde en vez de estar utilizando una irradiancia de 30, específicamente en estos bebés de 500 a 750 gramos, le bajan a 20 a 25. En lo que estamos esperando porque salgan los resultados del estudio de la fototerapia cíclica, que esto ya a futuro nos va a permitir ser más cautelosos. Lo que ellos intentan es tener unos valores de bilirrubina menores a 7, entre 5 y 7. ¿Cómo manejan la prevención? Está checando diariamente este valor. Por decir, si hoy el bebé al checarlo tiene un valor menor a 5, se para la fototerapia. Si mañana nuevamente sube a 6, entonces mañana comienzan otra vez la fototerapia. Esto igual va a depender del valor, ¿no? No quieren que sea mayor a 8, definitivamente no quieren que llegue a 10. Es un proceso tedioso, sobre todo para enfermería, de estar quitando las horas de fototerapia. Y generalmente por 2 semanas es donde están cautelosos. Si el nivel es mayor de la bilirrubina, no van a aumentar los intralípidos. En vez de estar a 2 a 3 gramos por decilitro, lo bajan a 1 gramo por decilitro. También evitan múltiples drogas, manejar procesos como la acidosis metabólica. Y también en los bebés que están inestables, pues ser muy agresivos con la luz. Pero él hace énfasis en checar los niveles diarios de la bilirrubina.
Muy bien, muchísimas gracias. A continuación, nos acompaña también la doctora Cortés González Sandra Ibet, residente en neonatología. Adelante, doctora. Si no está con nosotros, entonces que continúe la doctora García Cruz, Claudia Ibet.
Hi, doctor. I'm very pleased for this opportunity, and I want to ask you, what do you think about of the use of the transcutaneous bilirubinometer in premature babies?
Ah, I knew you were going to ask such a question. That's a very hard one. I'm not a fan. I think transcutaneous devices could be better. There can be better engineering. At the moment, they do not take into account the thickness of the skin because it's light going across, as I indicated, through various tissues. And the algorithms are not adjusted for the thickness of the skin. And the amount of fat changes, so the amount of bilirubin in the fat will vary in a premature babies. So I think it'd be useful in babies at say 32, 33, 34 weeks of gestation, but we come down to less than 30 weeks, I don't think they're useful at all. I think they provide a trend. If you use the same device in the same site in the baby, you get a trend. But it's not something that I would base treatment on. That if I have to use phototherapy, which is the main reason I'm checking the bilirubin, I'd have to look at a blood sample.
Okay.
So that's why we check it, just once a day.
Okay. Thank you, doctor.
Bueno, la residente preguntó, la doctora Claudia García Cruz preguntó sobre el utilizar el método de bilirrubina transcutánea, la medición. Y el doctor comenta que es una pregunta difícil, que él no es fan de estos dispositivos porque definitivamente pueden ser mejores. Al momento, estos dispositivos no toman en cuenta el grosor de la piel porque pues es luz que cruza varios tejidos. Entonces los algoritmos no están ajustados al grosor de la luz de los pacientes y también la cantidad de grasa es variable. Entonces estos dispositivos podrían ser útiles en bebés de 32, 33, 34 semanas de gestación, pero no son útiles para menores de 30. Él considera que no son dispositivos útiles para menores de 30 semanas. Dan una tendencia, es decir, si utilizamos el mismo dispositivo en el mismo lugar de medición, nos puede dar una tendencia de si está subiendo o está bajando la bilirrubina, pero él prefiere utilizar medidas como tomar los niveles de la bilirrubina sérica, aunque es una vez al día, pero pues así tienen como que más certeza de los niveles en estos bebés.
Muy bien, ahora sí, nos acompaña la doctora Cruz Miranda Michel, residente de neonatología también.
Good night, doctor. Thanks for the session. I would like to ask you what you think about the nice graphs that do not consider extra risks.
I beg your pardon? I'm sorry I missed that.
I want to know what you think about the nice graph that do not consider extra risks.
Yeah, the nice graph. I think Janet Rennie and her group did a wonderful job in putting together their perspective of the evidence. Again, it's a consensus opinion. I think they are a little bit more liberal. We are more worried. I think Dr. Mezels and Wachko and I were more worried, and so we based our numbers based on bilirubin albumin relationships and the concerns that we have. So I think you can use one or the other. I think it'll be very nice if somebody did a comparison between the two strategies, with the outcome being on hearing loss. If one, the success of a good phototherapy program is least amount of phototherapy, least incidence of phototherapy used with the least amount of ototoxicity. And though that study has not been done yet, encourage you to do studies like that. In the US, we're not using the NICE guidelines, so it really is not an issue for us. But I don't see anything wrong with that other than how they reach the consensus, and that's a problem.
Thank you, doctor.
Bueno,
Excelente.